These recordings are copyrighted material under U.S. copyright law. Federal law provides severe civil and criminal penalties for unauthorized reproduction, distribution, and exhibition. The purchaser agrees that these recordings will not be duplicated in any manner, nor will they be circulated outside the physical location of the purchaser to which the recordings were sent, without the written permission of FTC Reports Incorporated. The purchaser further agrees that it will not resell or make an exchange of any kind of these recordings. The information contained in these recordings should be an accurate and complete record of the public portions of the FDA Advisory Committee meetings. However, FTC Reports Incorporated assumes no liability for the accuracy and comprehensiveness of the information presented.
If I walk away from here just talking about this paper, I don't feel that I've really done my job, because I think the paper is very limited in scope.
Dr. Clausen?
I'd like to kind of add to what Mike just said about, using mercury concentrations in urine or even in brain as a good measure. I think one thing we have to remember is that mercury is not mercury is not mercury. You give inorganic mercury or mercury vapor or methyl mercury, you get completely different toxicities, you get completely different pharmacokinetics. And I think we need to be sure that we're talking about elemental mercury when we're talking about amalgams. And so, for example, if one measures the mercury concentration in the brain, it might not have anything to do with your amalgams. It might have all to do with how much fish you eat. And it's the same way with the placenta. Carbon is different than carbon in different drugs. We don't talk about carbon drugs. We shouldn't be talking about mercury. We're here talking about elemental mercury. And I would say that our best data that we have is the human exposure to elemental mercury from the chloralkali plants. Because there we know what they were exposed to. And we know what form that mercury was in. It was elemental mercury. So I think that's one of our best clues. And if we believe in the dose response, which most toxicologists do, that as you decrease the dose, you decrease the response. So therefore, what one needs to do is look at the high exposures first. And the high exposures is from occupational exposure that has happened, quote, around the world in various conditions and is still occurring, and see what's happening in those people. Okay? Then you work your way down to lower concentrations. And so I guess my message is that mercury is not mercury is not mercury. And by measuring mercury and thinking all mercury is the same is as foolish as measuring carbon. And none of us measure carbon when we measure blood levels of drugs, I don't believe.
Dr. Goldman.
I'm glad you brought up that point, because it's definitely a problem with all of the human studies, and except for a couple where they actually were able to speciate and look at the inorganic mercury versus the methyl mercury. But usually in studies, you do a total measurement of mercury in urine, you are going to see a lot of methyl mercury, or blood, or any compartment. And only a few of them. Now, the NHANES one did, and a couple of others did, but only a few of them did look separately at the elemental mercury. And the same is true, actually, for the toxicology studies. The problem with the chloralkali worker studies, and we could certainly spend more time dissecting them, I started looking at them, and they do have problems. They're not mentioned in the white paper, but the problems are problems that are kind of classic problems in occupational epidemiology, especially with healthy worker effect, lack of follow-up of retirees and people who are disabled and all of that. And those are terrible biases. And in my view, they're more biased actually than the dental worker studies, which also have biases that have been pointed out. But we could look at them more thoroughly, but we may find also, and I could not see anything in there to show that they had excluded fish consumption as well among some of those workers as possibly creating random misclassification of exposure. So I think that we have to be careful to just assume that they're better because they're human studies, because, like all epi studies, they're not controlled, and it's up to the researchers to really carefully make sure that they don't create biases. I wanted to go back also to something Roger said earlier about the human brain levels, and I agree that the brain compartment measurements are going to include methyl mercury. There are a couple of animal studies that just looked at inhalation of mercury vapor. And the Danielson study, which was not reviewed in the white paper, published in '93, where mothers were exposed during gestation, mother rats. There were measurements of the neurological performance of the rat pups. And also those rat pups were sacrificed, and they looked at brain levels of mercury. And all the groups had effects, so they couldn't identify a low effect level. But the brain levels are in the range of the levels that we see in human brains. I mean, for these pups, between 5 and 12 micrograms per kilogram. And so that's pretty interesting, I think. So I just feel that, one of the things that we have to conclude is that we have the major data gap in terms of the sensitivity of the fetus. I mean, every animal study that's published, of course, there could be publication bias. There are major effects on offspring, including, by the way, the same group, the Danielson group. They have a subsequent paper showing at least an additive, maybe a synergistic effect between exposure to mercury vapor and methyl mercury. And in the real world, we have both exposures occurring, and we should be concerned about that as well. And that's also not mentioned in the white paper, but again, it's a study that would not allow you to come up with a regulatory standard. But I come out of this very uneasy about what we don't know about both the exposure levels during dental procedures, what the transfer of that might be to the fetus, and what the impact of that might be on the developing brain. And everything that we know about other forms of mercury, methyl mercury, the time that seems to be the critical time is during brain development in utero. And so that would be the most important thing to know in terms of assessing safety, and we don't know it.
I'll let one more question, and I'll make a little summary, and then we'll break for lunch. Dr. Diamond.
It's more a definitional question. There it's stated as adverse health effects. We're getting very, very granular in our discussion with regard to causality. And we're getting into a lot of the specifics with regard to hypersensitivity and some of the mechanisms or potential mechanisms of toxicity. But is this definition that we're using more toward the regulatory definition that we use for adverse experiences that are common to drugs, devices, and biologics? Because that's a very, very different thing. Because in that case, these are associated with the use of a product, whether or not considered related to the product. And are we to look at within that context, or do we need to look at it with the specific to causality? Because that, might help to guide the discussion.
At this point, I'd just like to try to summarize what we've covered just the last few minutes. And in addressing it, would appear what I'm hearing so far, and Dr. Keepers will continue this after lunch, but at least initially what I'm hearing, particularly at least in answer to the part A of one, is that the direct evidence, perhaps mainly because a lot of the components that we don't see in the white paper and in the materials that are presented, that we can't see direct evidence really supporting or really refuting us. We have a big question whether we can refute anything given what we have in terms of information, but I would at least try to answer the first. That A appears to be what I'm hearing, and if anyone please respond to this, is that the direct evidence doesn't seem to exist that supports, that at that point. Does anyone care to comment on that?
I guess
Dr. Hughes.
if you take the two pediatric randomized trials, I would consider them direct evidence of the effect of amalgam versus non-amalgam fillings. You can debate whether they support or refute the occurrence of adverse health effects. They were designed to look at adverse health effects, so neuropsychological outcomes, not to look at a beneficial effect of those particular devices. So I would say that those are as close as we get to direct evidence looking at adverse health effects. They were designed, if you look at the US study, it was designed to look at or to detect a 3-point difference, I think it was, in IQ scores. The paper presents a confidence interval which has its bounds within or smaller than a 3-point difference. So arguably, if you accept that a 3-point difference is significant clinically, arguably they would provide direct evidence refuting the sort of adverse effect that the study was designed to detect. And if you combine the evidence from the two studies, maybe it's more persuasive. I think the caveat there obviously is that although these studies, I think, followed the children for 5 or more years, it is relatively short term in terms of how long those children and when they become adults might be exposed to the two different types of filling. And secondly, one study certainly mentions this, that a lot of the fillings obviously were in primary teeth, which were lost early in follow-up. So the extent of exposure to amalgam fillings, there's clearly a difference if you look, even at 5 or 7 years. But the extent of exposure may be comparatively small compared with levels that are, or the exposures being seen in a broader population. But I think, in my mind, they provide as close as we get to some measure of direct evidence of the effect of amalgam devices, and it's hypothesized that any difference there would be due to mercury vapor, I presume.
Dr. Goldstein.
Yeah, I agree. Prospective randomized trial is always the gold standard for detecting effects. But again, I think you need to also, in addition to the limitations Dr. Hughes had mentioned, there are also other potential ones. For example, what we're doing here is looking at a given population with a standard error around it. That's not to say that there isn't a group within there that might have had divergent effects that you couldn't detect because it's underpowered to detect it and the study wasn't designed to look for those types of things. So you get the answer to the question that you ask. If you take this group of children, given what happens to them in an intention to treat, this is what you get. But in terms of refuting a potential detrimental effect in a potentially very clinically relevant subgroup, you won't see that unless you look for it, and the study is empowered to do that. So with that additional caveat, I agree.
Dr. Goldman.
Yeah, no, actually, that's almost exactly what I wrote down before we started the discussion. I even think from those two studies that we can even have some idea if there is a subpopulation of that type, kind of, how important it is. I mean, it would probably, I think what we're talking about is that it could be a subpopulation that it is in the range of, 1%, 1 in 100, 1 in 1,000. these studies couldn't detect subpopulations and effects in subpopulations that are that small. And it's just the limitation of epidemiology, this kind of epidemiology just wouldn't be able to. It's not a knock on the studies. It's just simply an inherent limitation to the kind of studies that are here. I would also say, I read her study, and now I don't remember her name, the person who presented to us this morning, and the study that was published in Environmental Health Perspective on the dental fillings in adults, I think also provides the same kind of evidence. Even though it was not a prospective clinical trial, I was very impressed that they did a pretty good job controlling for potential confounders. They had decent exposure measures, not just teeth filled, and that it does provide some information about safety. Again, not necessarily that there isn't a subpopulation that's more sensitive, but in the general population of safety. And I felt that study was reassuring in terms of the fillings in the general population. But again, cannot refute that there might be more sensitive groups, and in fact I think to find that you would need to go about looking for them in a completely different way, and I hope we can get to discussion on that at some point, because I think at some point we ought to talk about what we might recommend to the FDA in terms of being able to not necessarily refute, but see if more specificity can be put around some of these. I don't want to say hypersensitivity, because I agree with what Michael said. We don't want to confuse it with allergy, because we're not just talking about allergy, but if we have sensitive subpopulations, who they are, how those might be identified, and some of the issues that we've heard about for the last couple of days might be able to be studied.
The last comment from Dr. Goldstein, then we'll break.
Yeah, and again, I think the way to frame our approach to all of these questions is that list that I ticked off when we had the presentation of the white paper, looking at the adequacy and of the methodology that was used to produce this, and the papers and the studies that are actually included here. That's the database that we're working from, and I can't be assured that that's adequate or not, based on the methodological issues that I raised.
Well, thank you. Thank you to all of you, and I'll be happy to let Dr. Kiepertz take over this afternoon, and I appreciate your support. And perhaps what we should think about during our break is that one of the things I'm sort of hearing in here is that as we go through A, B, C, and D, are sort of issue raisers, but they in a lot of ways, they don't really answer a question. And I'm not sure that they're framed as a question. You can say yes or no, or you could say, well, we vote one way or the other. Perhaps the components of A through D really just give us a little guidance then to affect questions 2 and 3 as sort of, they're really contributors to that, because they make up a point of whether we feel that they clearly and objectively present the knowledge that we have, and we can say yes or no. And given that, do we have conclusions? And if not, then we need to be able to go back to the FDA with why we feel that white paper. So I guess I feel that, and think about this during lunch, is that we really have 2 questions to answer, which is 2 and 3, and then A through D really are sort of the factors or the contributors to how we feel that those 2 questions should be answered.
Can I just remind people too, you can think about it, but don't talk about it.
Yeah.
That talk happens here on the record. Okay, it's very important for the public to hear that talk. Okay, so think about it, but talk about architecture.
We'll break for lunch at this time. Please be back shortly after 1 o'clock. Thank you.
The open public hearing is closed. This is a period of time for discussion amongst the members of the committee. Members of the committee can address questions to each other. They can address questions basically to anyone they want to. Prior speakers, members of the public, you're allowed to address questions to whom you want. Public cannot address questions to the committee. No one's theoretically supposed to ask anyone anything unless I recognize you. Even though Michael or Daryl are not here right now, between the two of us, we'll try to catch your eye, get a list of people. So if you want to put your hand up, put your microphone on. Once Daryl or I catch your eye, we'll put your name down and make sure we have you on the list. Try to get around to make sure that everybody says something who wants to say something before we go back to someone who's already had something to say. I think it is important for the FDA and for the public for people to have their say. This is the chance. 4:30, we're done. We will have voted and we will have had our say. And then it's over. So this is it. There's no other information to be gathered or a time frame in which this is going to happen. It's now. The consultants are deputized as voting members. The only individuals who do not vote in this are the industry representative for the device panel, the consumer representative for the device panel, the patient representative from the device panel, and the industry representative from the PCNS. So those four individuals at that end of the table do not vote, however, are active members in the conversation. Everyone's point of view is important and valued and should contribute as they see fit. But when we actually do come to the vote, which will be on questions 2 and 3, are the really only votable questions. The discussion will be around question 1. I think, in fact, we'll probably, not to presage things, but I think the discussion we want to really engender around 1 will lead to voting around 2 and 3. When you vote yes or no. You can abstain, but I don't think that's so useful. In fact, in many of these things, I think for the agency, Dr. Alderson can comment if he's here if he wants to, but that it's better to say no and why or yes and why than just a no and a yes. That not a lengthy discussion, and when we vote, if someone says, I vote yes and such, this is the reason, I won't entertain engagement of that person's statement. So if Dr. Goldstein votes yes and says blah, 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 I won't let Richard ask him a question about his reasoning. We'll go around and let everybody vote. And then, so you'll have an unrestricted coda. You can say your little piece about why you vote. People understand that or comfortable with that scenario? Questions about that?
Question here.
Yes, please. And I can't, please.
Yeah, the question regarding the vote, I was made to understand there are 3 categories of response, one being, I suppose, no, one's yes, and then there's qualified yes or no. Am I correct in that, or am I misunderstanding?
Yeah, that's, I guess it would be useful to vote yes or no and explain yourself either way. Because, again, this is not like, Dr. Alderson, do you want to comment at all about that, on what would be useful for the record and for the agency?
I would be glad to. I think you're thinking the same way we are. Any qualification that you can give us on your thoughts on these issues, we want to receive that. We really genuinely want your input on the issues we've presented before you. And it's clear from listening to the discussion, you've got a lot of issues. So, give us that feedback. And while I'm on this, there's a couple of things that we've talked about during the lunch period that we really see you're having some difficulty with, and we'd like to encourage you to help us on that. And the first one is on this issue of whether to use the urine levels or not as a measure. Yes, that's one thing we've been using. But if that's not appropriate, give us feedback on that. We want to know how to do this the best way. So that's the reason you're here. You're the experts. Help us. The second point that the folks picked up on is from Dr. Porter. He has mentioned 2 studies regarding brain levels. We're not aware of but 1. So help us identify both of those, if you will. But as during the discussion this afternoon, as things come up that we're going to prod you a little beyond maybe where you are, we will do that. Is that helpful?
Yes, thank you. I think that's very helpful. So to reorient ourselves, Dr. Zero?
The point that was just raised, I think, to me personally, is a fundamental issue. And that is urine mercury levels, a validated circuit, a valid circuit of body burden. Is body burden the issue here, or is it, what are we talking about here? And if we're talking about body burden, is urine mercury levels a valid circuit? Frequently, when I work with the FDA on the other end of the street, you know, when we're putting in submissions and for consideration, they come back to us with the question, is this a valid surrogate? So I want to turn the tables here, because I really think it is a pivotal and key point here.
So thank you. Let me just frame up, at least from my perspective, having the bully pulpit part of where we are. I think it's important for us to realize that we do have to come with some concrete responses to the questions, and I think that which are, as you've already seen laid out, and I won't reiterate them, but you can see that important aspect is objectively and clearly present the current state of knowledge about the health effects of dental amalgams, and are the conclusions of the white paper reasonable? Now, one thing we may want to point out, which I've already heard articulated, is that the current state of knowledge is inadequate to fully address some of the questions. And I think that would be very important. But a very important thing here is, does the white paper, again, objectively and clearly present the current state of knowledge? We could want the current state of knowledge to be a lot different than it is. But I just want to keep those two issues separate. Dr. Alderson.
And that's an important point to us that I failed to mention earlier. The word data gaps has come out, that a number of the committee members, we need that badly. Your identification of the data gaps that exist to help us make this decision on the safety of amalgams it's so vital to us. So, in your consideration of the questions, yes or no, a qualifier is, but here's a data gap. That's critical.
So returning to some of the discussion about the questions 1A through Part D, I think that some of the things we heard, and Dr. Burton already summarized it, but I'll just say it again, some of the things we already heard, there are 2 randomized trials. There's the ranch hands and the New Zealand Defense Forces, and I'm going to forget and say her name wrong, the Factor-Litvac study, all of which are fairly large population-based kinds of studies looking at the issue of, is there an association between amalgams and adverse health effects? And those relatively high-quality kind of studies, in terms of drawing inferences about a relationship, to my read, and I haven't heard comment to the contrary, do not provide evidence of adversity from dental amalgams. Now, there are limitations to all those studies, but and I'm not aware of other studies of that quality, not just using the white paper, but doing my independent searches of the literature, of other studies of that character and quality which have substantively different observations. Is that in keeping with people's, I'm not discussing the issue of urinary measures or other, but just the phenomenological association of amalgams and adverse clinical
I'm in agreement with that, and it's just with the same, proviso that we talked about earlier, which is that these studies, by design, cannot tell you about subpopulations that have, genetic susceptibilities or other special susceptibilities. But, for what they are designed to do, I would agree with what you said, so.
I think that brings to light another point. And several of the articles, again, already alluded to, Dr. Factor Litvak's paper, the Kingman paper, also with Kingman is the ranch hands U.S. Air Force data, and the Ellingson as the chloroalkali workers, so slightly different. But one of the interesting things in looking at those is there are urinary concentrations about the reference population, as well as the exposed populations. Also, the Bellinger randomized trial, it's interesting to see just how much variability there are in these measures of urinary excretion. In the, I believe it's in the Kingman, there are excretions which are graphed out. You see there's tails out, but they're quite high excretions, 35, as opposed to these sort of lower levels, 5 to 10. So anyway, just picking up on that even within non-exposed populations and certainly within exposed populations, there's a great deal of variability in whatever measure we have of mercury exposure.
But I'd just like to point out the question, since you're talking about urinary levels, that in the back, in the note from Dr. Boyd Haley, he makes the point, and I think that this may or may not be correct, but if it is in part correct, it needs to be part of the document so that we know where the excretion of this drug comes from. And at the moment, it's not in the document. It has been published and verified that over 90% of mercury excreted by humans leaves through the biliary transport system of the liver and excreted in the feces, not the urine. Urine mercury levels are well documented not to reflect exposure under many conditions. Now, I don't know if that's 100% correct, but the document, again, from a pharmacologic standpoint, is weak in that it does not address this issue.
Yeah, the WHO document's different in that it says that urinary excretion is the best measure. So there's inconsistencies amongst reputable documents about the relative utility of these measures of exposure.
Yeah, I would argue that urinary excretion is the best estimation of inorganic mercury excretion, but it's not a very adequate measure. There are tremendous differences, and especially in people that are under conditions of steady state, the amount of mercury in the urine is not a good measure of exposure or body burden. So I don't think that necessarily having measurements of mercury in stool will give you a better estimate of inorganic exposure. Most of the mercury that's excreted in the feces is from the methyl mercury because it cycles through the gastrointestinal tract. You get the hepatobiliary excretion. There's another surrogate measure of mercury which hasn't been used very much, and it's also riddled with problems, but one can certainly look at, couldn't do it with me, but people that have a lot of hair, you can get a very nice profile of mercury exposure in those individuals. It'll be more recent, but it's a good measure.
Dr. Clausen?
Yeah, in regard to urine concentrations, this is one biomarker of exposure. Is it perfect? No. And I can give a classic example is a number of years ago, Tom Clarkson, who's a big mercury expert, as most of you know, had an NIH site visit coming. So for 10 days before the NIH site visit came, only thing he ate was fish and measured his urine concentration, of mercury. And he got the $10 million grant. So, but it is an approximation. There's nothing better that we have right now for measuring exposure to amalgams that I'm aware of. But it's not perfect. And again, so much of it depends on which form of mercury people are exposed to and are concerned about. And, a lot of the information that lay people have on mercury is from methyl mercury. And so, we want to make sure that we separate the methyl mercury from the elemental mercury.
Dr. Dorson?
Yes, I have if you don't mind, a response to an earlier question of Dr. Fleming. And then I have a question on myself to the panel and perhaps Dr. Clausen. So Dr. Fleming, you asked earlier about dose response and safe doses and safe concentrations and things like that. Our colleagues at FDA have done a very good summary of safe concentrations, the RFC or the minimal risk level, in the document. I worked on the EPA's value many, many years ago. I'm not beholden to that value. It was done by an expert committee at one time, so it was derived by an expert committee, and we just did some work inside EPA and then put it up on EPA's IRIS. EPA's done some good work since then. ATSJR's done lots of good work confirming that, and the Dutch, also the RIVM, which is the Dutch Institute of Environmental Protection and Public Health, has also come up with a similar safe dose or concentration for methylmercury. All of those definitions include words to the effect of sensitive subgroups are protected, and there are uncertainty factors used when scientists are not sure, and they tend to be somewhat conservative. None of those definitions say every sensitive individual, and so each of these organizations has used words on hypersusceptible or immune-sensitive people might not be protected, or an idiosyncratic response, which means a response that it just isn't predicted. But all sensitive subgroups are considered in those estimations of safe dose. And in this particular case, the safe doses that are being used by our colleagues at FDA look to be well wrought, especially the other two. I won't talk about the EPA value since I had part of it. They look to be very well wrought, and the literature review that the FDA has done is consistent with looking at other studies that might affect these chronic, a little bit every day safe doses or concentrations. So that's the dose response question. I hope that helps a little bit. That doesn't mean that every sensitive individual is protected, but it does mean sensitive subgroups are considered.
May I respond?
Yeah.
To that just quickly? My concern is, as I read all this literature, is there so many expressions of probability used, which is an entire discipline in itself. Right. For example, you see the words rare, small, isolated. So to me, I think that term needs to have some kind of definition meaningful for us. And in a sense, if we're trying to say that there are no adverse effects from dental amalgam, I think we need to have some definition of what sensitive means, or
right,
what rare means. In other words, is there a number we can attach to it realistically?
Well, the idea of sensitive subgroup has been fairly well established. There are either populations of children or pregnant mothers or elderly individuals as subgroups that are considered in these estimations of safe dose. However, when you get into rare and hypersusceptible, those kinds of words are not defined because the science is not precise enough, the risk assessment science, to define those. What is of more concern to me in this dose response is not whether the safe dose protects every last person on the planet. It may not. It may not. Is, do we have exposures that are exceeding the safe dose? And that's when I talked about characterizing the off-gassing of inorganic vapor from dental amalgams, either acutely, day 1 through day 14, to chronically or long-term. And it looks like we've got a handle on the long-term off-gassing. It's just a little bit. Well, what about acutely? And that's maybe an open question. And actually, that leads to my question to anybody on the panel. and this is prompted, Dr. Clausen, by you, mercury is not mercury, et cetera. We do have papers in here, and I'm looking at the paper in particular by Dye et al. It's urinary mercury concentrations associated with dental restorations, et cetera. They do have mean levels in the urine and also standard deviations. Very good at getting to the variability in the population. And they have in here a mean value creatinine adjusted in pregnant people of 1.2, 2 standard deviations above that is 3.38, and this is micrograms per liter creatinine adjusted. And in the white paper, we have an adjustment for that to find out what would be in air. Now, I can make that adjustment. It's real easy. I just divide 3.38 by 1.22. It's in the paper. The question is it legitimate to do that adjustment because it assumes that everything in the urine is coming from the amalgams? And so that's the question. Is that a fair assumption? Is it 50%? Do we not know? Thank you in advance.
Dr. Zero had it. Okay. Dr. Goldman.
I mean, I've asked those data come from the CDC, and I've asked them, and they tell me that actually the majority, when they do speciate the mercury in the urine, the majority of it is from methylmercury in the general population. It's not an occupational population, but in the general population. And actually that they kind of assume when they're looking at those levels that they're looking at a methylmercury exposure. Now in this paper, is it not broken down? I thought the Dye paper, they actually gave a breakdown of inorganic versus the methylmercury. I might have them confused though. It seemed to me that they did give the inorganic mercury level in that paper, but.
Well, the footnote to the table saying total mercury, well, that's in blood. Okay, I'll look.
There's a urine.
Right.
Yeah, it might be just total. I mean, there are other issues as well, and as has already been said, the urinary mercury measurement is not perfect, and even less so when it's a spot measurement, because there can be variability even within a day about excretion that has to do with metabolic state and numerous things. And then the creatinine correction is to at least try to correct for the dilution of the urine. But that still doesn't give you as good of a picture as if you do like a 24-hour collection or a longer collection. But, in practice, nobody is going to do that with a large population. You're just not going to be able to do that.
So, two issues I hear people identifying a knowledge gap is one, an accurate measurement of the exposure burden with acute manipulation of amalgams that, for example, could be the placement or removal. Dr. Dorson, am I hitting on that accurately?
I believe so.
And perhaps even, but to a lesser degree, the chronic exposure from them. And secondly is a good measure, there's tolerably good measures, but perhaps with a certain degree of imprecision regarding current exposure as vis-a-vis body burden. If I understood correctly, there are Dr. Ashton, there are individuals who will have different body burdens but might have the same urinary excretion just based on the chronicity of exposure. So, Dr. Porter.
I just wouldn't downgrade too much the total body burden on the chronic basis, because we know that there's accumulation of this drug in various body tissues. And what that accumulation means right now, in my view, we really don't know.
We wouldn't downgrade body burden too much. What do you mean?
You emphasize the acute event, and I have nothing wrong with the acute event. I'm sure that there's a lot of mercury floating around the acute event, but you said, and to a lesser degree, the chronic exposure, and I just want to make sure we don't downgrade that too much, because that may be a very, very important factor.
Yeah, I think some of the things we saw with chelation and that transiently reducing blood levels, but then they go back up, and other evidence in the white paper already suggests that there's a depot effect in storing and an increasing body burden. And I did not see, and perhaps people are familiar with other more direct measures of
There is a
body.
beautiful animal study that shows that there's, and in 11 days, there's tremendous accumulation in the kidney. It's the Davis study, page 31 in the white paper. You have to be careful because the urinary levels are in nanograms and the other are in micrograms. So-
And this is from amalgams.
It's just inorganic.
Yeah, it's the vapor paper. But
Intranasally administered.
we're in agreement that there is a substantial accumulation of this drug in body tissues, and we don't know what this means, either on an acute or chronic basis.
Actually, I guess we should be careful, Dr. Porter. There is accumulation of elemental mercury, is what we're saying.
Yes.
I think lingo is going to be, vocabulary is important here.
Fair enough. Fair enough. I stand corrected.
Well, once it crosses into the brain, it's not elemental. It's going to get oxidized to Ag++. It's inorganic, but it's not elemental at that point.
Inorganic, right? So,
Yeah, other tissues as well, right.
Dr. Taylor.
I just had a point of clarification. Are we, in the chronic exposure, where would we put the vapor that might be created with the chewing and the brushing? And as we talk about our exposure, because we had the acute exposure with the removal or insertion of the amalgam, then we had the chronic exposure, if I understand, with the accumulation in the tissues. So then we have one other potential exposure, which might be the volatile mercury that occurs with the brushing and chewing and things like that.
So there have been several things we've seen. One, mechanical disturbance such as chewing can increase levels. There's at least one report of nicotine gum chewing increasing levels. So there appears to be ability to enhance release with certain things. So I don't know how, I don't think we know how those relate to the other acute perturbations.
Yeah, let me just step in a little bit. In the risk assessment science, we try to keep things as simple as possible. So, not that we ever always succeed, but in the case of the chronic safe dose, we're going to say, or safe concentration, we've got 3 examples, 3 different organizations giving almost the same thing for organic vapor. I'm sorry, vapor itself, mercury vapor. It's going to be that concentration daily, 24/7 for your whole life. And if you're below that, if you're off-gassing in your teeth, the amount of vapor that's going to be less concentration 24/7, that's going to be considered safe, including sensitive subgroups, not necessarily every sensitive individual. Now, the other side of the coin is if you are worried about an acute event, risk assessment scientists estimate a safe concentration for acute exposure. And ATSDR, I should have looked it up, they also do 1 day and I believe 10-day or shorter intermediate safe doses and the chronic value. Not surprisingly, those safe concentrations for the acute tend to be higher just because that's how toxicology works out. Usually you can take a larger concentration, shorter time.
Unless it's fetal effect.
Unless it's fetal effect. So there are ways to do that safe dose and compare that then to the exposure if you know it. Hopefully that helped a wee bit.
Dr. Lesker?
Yeah, I'm a little.
People didn't understand.
I'm a little confused though, Michael, because you put a lot of weight in the reference concentration from EPA, and it was duplicated by ATSDR and by the Dutch. But I don't know about the Dutch study, but both the ATSDR study and the EPA study used the same data set to establish that reference dose. And the 24 hours and the uncertainty factors, it's not going to make it change that much, the differences between how the different agencies do it. And that study was a little frightening to me. From what I understand, this is the Farwell study. I mean, it was a good study and probably the best at the time to do that with. But it was a small population, it was 25 workers, and it didn't have a no effect level. And so you probably designed it with you guys are interested in cancer, you're not interested in linear relationships, so you probably did a threshold sort of thing and drew a line. So, how good is that data set at the low end?
Well, those are good questions, and that's what the reevaluation by ATSDR and RIVM and EPA and now FDA, they looked at the newer studies to try to replace that study. And it was, as you said, it's got some flaws. They used an uncertainty factor of, I believe, 3 with all 3 organizations, that's RIVM and ATSDR and EPA, to adjust the minimal low observed adverse effect level down to the expected no observed adverse effect level, and then a 10-fold uncertainty factor for within human variability. And then EPA used some database considerations as well, which is their habit of doing. So that's, in all cases, the uncertainty factor was 30-fold for each of those organizations. And subsequent reviews by each of these agencies has not found something better than that study, even though it has its limitations.
Could I explain that a little more, because I think it's for the the thing about risk assessment is that it's very narrow. What you're trying to do is very narrow, and that is that you're trying to kind of come up with the equivalent of what's the speed limit, what is a number that we can say is a safe number. And only a very narrow band of studies, even animal studies, will support the development of that kind of a limit. And so there are lots and lots of studies that are quite relevant to the discussion, the questions we've been asked, that you could not use for doing a different risk assessment. And so when they say, we reviewed the newer studies and there's nothing better to replace what we've used before, it doesn't mean that the newer studies didn't provide new scientific insights or new information about risks. That's not what it means. What it means is there was nothing in the newer studies that would allow them to set a different speed limit. Because very few studies are actually designed to do that. Most epidemiology is not conducive to doing that, for example.
And I presume all the panel members read and thought about the information, not with just are the reference doses and the reference concentrations accurate and good measures, but the totality of the risk. Dr. Zero?
I just trying to understand where in this reference dose analysis we have the data to understand what would happen in an adult patient that has a chronic body burden from various sources of mercury. And then on top of that, we put an acute exposure. Where is that information? In any of the analysis that we've been looking at?
I don't think we have that.
And that goes back to the open research question is what is the off-gassing of mercury vapor from amalgams, either in the acute window, which I think there is data on that, but I haven't seen it. I think Dr. O'Brien has some in vitro data for off-gassing of mercury, from amalgams. So we do have data. And then in the chronic window, when it's just a little bit eking out each day, and then the episodic increase, I don't know that we have data on that either. That seems to be a data gap.
Dr. Honan?
Yes, I just wanted to share Dr. Goldman's concern about the fetal exposures and that being a fairly significant research gap, and what we do understand is what effect it might have, especially during early development. And to that end, I was wondering if the practicing dentists on the committee could shed any light on the standard of care for pregnant women in the U.S. currently. Is it only emergency care for things that cannot wait until after pregnancy? Is it fairly typical to be removing and installing fillings during pregnancy? What would be the typical standard of care?
Please, Dr. Fleming.
Well, I can tell you this, that for example, to give you an example of a unique situation, it's in the hygiene department of your practice. I personally would never think of replacing, removing, or installing anything in a woman who is pregnant. So that's my personal view. The issue in hygiene departments is that the hygienist will take a prophylaxis cup if the patient has amalgams, and they'll polish those amalgams, and the mercury release rates are dramatically increased. That's the acute hit that they get, not to mention the hit that the hygienist gets in the field around the oral cavity. So the big problem, I think, that you face with pregnant women is not so much the installation and removal in the pregnant woman, but it's in the maintenance that's often emphasized during their pregnancy. For example, dentists are very quick to recommend that they need to be cleaned because they can get pregnancy gingivitis and things of that sort. So the cleanings are emphasized. So I think some attention needs to be given to keeping that prophylaxis cup off that amalgam.
Dr. Burton, were you done?
Yes,
you.
that's just my perspective on it.
I guess my comment would be a little different. I haven't practiced general dentistry for a while, but I've managed large dental clinics both in the military and where I'm currently at, where we have both a number of hygienists and a number of general dentists. And my comment would be that there's really is not particularly in terms of providing general dental care, which is what I would put this under, whether you're placing initial restorations or replacing restorations, there's really not a restriction, and I'm aware of, that I've ever had in any of those facilities. So they at least potentially, if someone came in and they've broken a filling, they're always very acute, or during their pregnancy, are very more aware of their overall health and well-being. And I can honestly say I know that those are replaced. And if we have, in our particular state, where we also take care of a number of Medicaid and Title 19 patients, interesting enough, they get some of them become eligible for care because they're pregnant. So they will come in and get large amounts of treatment done during their pregnancy because it becomes covered during that period. So I guess I would say, in answer to your question, yes, I think that the standard of care, and I'm not trying to prescribe what that is, but I would say I'm not aware of anything out there that says, no, you would not treat them, you limit care, those kind of things. So they are going to be exposed to either initial restoration placement or potentially replacement during the time that they're pregnant.
Dr. Goldstein?
Yeah, as I'm thinking about this, again, I'm not a toxicologist and I'm not a dentist, so I'm just looking at it, just standing back a little bit. We're looking at these levels as if these are dichotomous variables, that you reach this threshold and all of a sudden there's risk, and below this threshold there is no risk. And these are clearly continuous variables. They're not dichotomous. So setting a, quote, level that's safe to some degree is sort of in the eye of the beholder, and depends upon all these other factors that we've been talking about. Is there a population that may be at risk at whatever level? Is there genetic variations that increase total body burden that may have an effect? And I don't know the answers to these questions, but again, as we're thinking about gaps, things that we don't know, those are things that we don't know. And as we're looking at epidemiologic data, although they're very helpful, we all know that we can be misled by epidemiologic data because of unmeasured confounders in all sorts of different directions. So those, I think, are also things to consider as we're looking at the totality of the data. There is one question I also just have, just as an aside. One of the statements that we heard over and over again through the public testimony from many dentists was that that resins don't serve as a substitute very often for these for amalgam fillings. The clinical trials that we have that we have to review, the prospective randomized clinical trials, none of the people that were randomized were dropped because of technical reasons that a resin filling couldn't be placed. If you look at these things, there may have been other reasons that people were dropped, but technical reasons related to putting a filling in was not a reason for excluding any of these folks once they were randomized in any of these studies. So if one of the other panel members who knows about these things could tell me what is this really, how big a problem is this? Because it didn't seem to be a problem in the randomized trials.
Please.
Manway? I know something about the New England amalgam trial, although I was not involved in it. But I think it has to do with the study design, and it was purposefully designed to enroll children who are older and without medical problems. So by those two criteria alone, would imply that the patients or the individuals would be cooperative for both types of restorations.
Were you thinking about other technical issues there? Or?
Yeah, and some of the discussions that, again, from the public comment from dentists, me not being a dentist, I have no frame of reference for this, was that there seemed to be not only young kids that wouldn't sit still, but other technical reasons, especially in these back back teeth. All of these studies apparently did these things in back teeth, so that didn't seem to be a problem. I know that obviously if you've got a really young little kid that's squirming around, that might be an issue. But again, I don't know the answer.
Oh, I'm sorry, go ahead.
Clinically, as a pediatrician, I can remember very well in the clinics. I mean, it's not just young kids squirming, but you have kids who are fairly big who are constantly seizing that you need to treat. In some cases, I mean, you can't stop the seizures, and you have to treat. So, some of the situations truly are very difficult, and there's just no doubt of that.
And in terms of the study design, again, it's looking at two different types of restorations, but that doesn't preclude other treatment options that may have been given to the patients. For example, a tooth might have been extracted because it was not restorable. A crown could have been placed on because a filling was thought not to be appropriate. There was also mention about, for anterior teeth, the restoration of choice was composite for aesthetic reasons.
So, you wanted to mention on this topic, Dr. Burton?
Yeah, I just want to comment. I mean, I think that from a dental standpoint, I mean, the transition between a composite restoration and an amalgam has been primarily the fact that amalgam has always been at least a stronger material, therefore can support more load to it. So you made a comment about back teeth. Well, yes, there's more occlusal load on a back tooth than an anterior tooth. And the fact is, as you have less and less tooth structure left, you're replacing more of the tooth structure with an artificial material. You need a material which then is inherently stronger than and again, it's always say it's a difference between a plastic and a metal, if you want to look at it that way, and it would take more load. And as dental materials have improved, that line has blurred somewhat between that differentiation. But I mean, I think that when I look at this, and again, dealing in that age of a pediatric population, you don't always have patients, those patients don't always require big restorations. Okay, that's, again, sometimes in adults it's because they've had multiple episodes. I had a tooth, I broke part of it off, I got another filling, and that's why they end up with larger amalgam-based restorations. But there are always alternatives.
Dr. Marr?
I wanted to comment on the issue of pregnancy. Although I'm not a general dentist, but I know my academy, for example, prevents us from treating pregnant women, and particularly in the first and the third trimester, where you have the placental barrier that is pretty loose and open for contamination. And usually that recommendation goes, if there is no necessity of emergency, we should not treat pregnant patients. So that's the recommendation that we have on the American Academy of Periodontology. And on the other issue that I wanted to comment, before addressing the white paper, I wanted to see whether the committee would be in favor of revisiting the approach of looking at the literature and making sure that the literature has been addressed properly with parameters of using 2 or 3 search engine to make sure that we give credit to the whole situation before addressing the whole white paper.
Can we come back to that? We'll leave that open on the table, Dr. Sacco.
I was going back to the question that Dr. Goldstein raised. Having just had a wisdom tooth mercury filling, I guess, replaced with a composite, it's interesting to hear this whole discussion. But I heard in the first speaker that there were other reasons of why amalgams may be better than composite, including recurrent caries and bacterial infections. So I think the risk-benefit ratio between, I sense, not just the cost issues we heard about, but the amalgams versus the composite brings up other issues and other potential issues besides just the ability to do this in children. If I read I'm a neurologist, not a dentist, but I did hear some other benefits of amalgams over composites.
Dr. Zero and Dr. Burton, do you want to answer?
By the way, I'm a preventive dentist, so I try to avoid ever picking up a handpiece. I chair the department called Preventive and Community Dentistry, and if we prevent disease in the first place, there's no need to place a restoration. So, and tooth decay, dental caries is a totally preventable disease. We have all the knowledge base to do that. So I need to get that on the table at some point in this discussion. But there's one other, and by the way, to qualify myself as a restorative dentist, I went to Georgetown, graduated first in my class as a restorative dentist trained, so I know how to do these restorations. The one issue that does come up with amalgam versus composite is salivary contamination, and then in certain areas of the mouth, it's very, very difficult to isolate the tooth to place a restoration without salivary contamination. So that's one of the issues that has come up by the speakers earlier in the session. The other thing we need to also think about is that material sciences is progressing, and newer and better materials are coming down the pike that probably will equal, maybe hopefully exceed the qualities of amalgam. So I think we have to think now and also in the future, and I think there's things coming down the pike.
Dr. Burton?
I would like to agree with that. I wanted to address what Dr. Omar said, in the fact that it wasn't the thing that we advocate the cure, but is there a prohibition against it, should I say that? We do the same thing in terms of, the truth is many times women are unaware that they're pregnant during the first trimester, so again, they may have extensive treatment done because we normally don't sedate patients during their pregnancy without clearance from their OB, things like that. And during the last trimester, we try to stall them off, you want to look at, because you've got some 8-month pregnant female, that's really not the ideal time from positional issues and comfort and things such as that. But again, I would agree with Dr. Zero that I think that a lot of us, myself being out of dental school 30 years, believe that a material science would take us past this point, because the other issues you mentioned is salivary contamination, but also the ability to isolate it. It produces a smoother surface, which is more maintainable from a periodontal standpoint. There are other issues other than just strength and things such as that. But again, probably material science, bluntly, 20 years from us, may take us past this point.
Dr. Fleming?
I wanted to address Dr. Goldstein again about, did I understand your question to be the technical differences between the placement of amalgam and composites perhaps being a factor in the...
It was a more general, it was just a more general question. As I think about these things, I think about risk benefit, okay? And in some cases, you have risk and you don't know the level of risk, and there may be vulnerable populations and maybe not. And then on the other side, there are potential benefits, and we read about some, maybe it's more resistance to caries, et cetera. But then you have to also look at the other side of the coin, and that's what's the potential alternative and what's the upsides and downsides to that. And my comment was based upon all the comments we heard from yesterday and this morning from a number of dentists saying that that there is no alternative in many cases. And then I was just commenting based on the randomized trials that we have here, where all patients were, once they were randomized, were enrolled and got one or the other. And one answer to that was, well, it may be an inception cohort bias in that they only took people who they could do either to begin with, although I didn't see that as being one of the criteria for inclusion. But but again, I didn't know the answer to that. So the issue about about the saliva, if that were an issue, then I would have thought that they couldn't have done it in any of the in one group of kids or another, and they would have been selected out because we tried doing it, we couldn't keep it dry, so we had to do the other. But that didn't happen here.
Right, so what I was getting at was from a technical point of view. I do composites very frequently, and so the technical difficulties in installing them, once you've gained experience, knowledge, and understanding as to how to use them, you can use them in any indicated tooth, including a wisdom tooth. It's not difficult to do that. It's extremely, it is difficult, this business about moisture contamination, the newer rubber dam materials that we have make this, it isn't a non-issue, but there are very few areas where I cannot get a composite if I want to get one in there with a rubber dam on. I would just as soon have a rubber dam on to eat lunch with if I could do it. But we use it routinely in the practice. I might add vinyl dams and not latex dams. which is another issue entirely. But still, the technical difficulties become moot with experience and technical training.
All right, I want to sort of redirect our thinking back to looking at some of the questions, and I'm just going to surprise my colleague and friend, Dr. Hughes, here. And just, you commented earlier about and direct evidence and the constraints on that. You just want to, where are you coming down on that? Make sure I understand your position.
I guess part of the comment was to make the point that there was direct evidence in several of these studies, I think, about the issue of adverse health effects of amalgams. Whether they support or refute the occurrence of adverse health effects, I think, is unclear. I don't think any of these studies were really designed per se to refute the question. None of them were equivalence designs, non-inferiority designs in the context of clinical trials. But the point that I was trying to make was at least the randomized trials certainly suggest in children that any true difference in the outcomes that were assessed are likely to be relatively small. But I think it's important to put the caveat on, we're really looking at quite short-term effects there. And a lot of the discussion has been about sort of chronic, long-term effects over potentially several decades.
Thanks. I know it wasn't part of the white paper remit, but I did look at the Swedish dental assessment, which is on the dentalmaterial.gov.se on this, and it's pretty much consistent with the FDA white paper, aside from one issue. But I will just read a sentence. I thought it was constructed rather well, considering it's probably written by a Swede rather than a native English speaker. But it says, at present it may be considered unproven, comma, but not excluded, comma, that subclinical psychomotor functional impairment caused by mercury is demonstrable in groups at the mean exposure level for amalgam bearers. So let me just give you that again. At present may be considered unproven, but not excluded, that subclinical psychomotor function impairment caused by mercury is demonstrable in groups at the mean exposure level for amalgam bearers. It goes on to go through a number of other clinical conditions and arrive at essentially the same conclusion, that although there are lots of concerns and hypotheses why it may be so, that this is the conclusion. I think there's some important things there. Unproven, not excluded, mean exposure level for amalgam bearers, which leads us to some of the things that some of the designs have not been intended to exclude the possibility, but it is unproven, certainly at predefined measured levels of toxicity, particularly the 3 IQ points, for example. But that there are, at least from my read of looking at this, of just the data on people who, on the studies I already alluded to, there's a remarkable degree of variability on this parameter. Maybe not that remarkable in the toxicologic world. Again, it's not a world I live in that much, but there certainly are long tails of urinary excretion levels and other things. It seems like there are potentially vulnerable subsets, not in the traditional sense, not children, pregnant women, elderly, infirm, but those who, for whatever biological characteristic, and we've seen data on some of the potential explanations for that biologic variability, there may be individuals that are poor excretors, higher body burden accumulators, or whatever, that may be linked to some of these clinical phenomena we've heard about. Dr. Porter.
Well, I just want to reiterate what you just said, because I've been saying that earlier, that if you look at the brain levels, there's tremendous variability even among the similar groups with similar amalgams. Now, there's also a dose-response curve. The more amalgams you get, the more there is. But in the high group, there was a range from 20 to 500. So there's tremendous variability even in small groups. This was 18 cadavers. So what this would expand to, if you expanded that or modeled it to the entire population, you might end up with a tail, as you put it, of patients who have very high blood levels in their, very high levels in their brain.
Dr. Diamond?
Yes, I think you made a very important point, and we see this often, in pharmacologic studies when we try to model on pharmacokinetic and pharmacodynamic parameters. You can see efficacy in a large cohort of patients, and we can construct very nice population pharmacokinetic curves, but when you start looking at the individual patient's data, it's all over the place. So what you're saying about individual variability is I think, very important, not just from an efficacy standpoint, but also from a safety standpoint. I think it's important data, but it's just one piece of the puzzle.
Dr. Lee?
Yes, I would like to come back to the question itself. The challenge I'm facing when I try to answer the question, the first one particularly, is probably related to the way the question itself stated. It asks us for evidence, and particularly in directive evidence, to support or dispute the possible adverse effect of amalgam. Is in toxicology studies, many times you find the negative results. That means you find no toxical results as defined by that particular test. And there have been debates regarding how to consider the significance of these negative findings. In 80s, there was a discussion regarding how we consider the significance of the negative finding in the carcinogenesis study. And if we find a chemical that does not induce any carcinogenic effects in a particular study system, and whether that is significant. Logically, it's much easier to prove something that exists, like the testimonials we have heard. They experience these suffering. They are there. It's easy to see and easy to be convinced. And how about the result, the finding that did not find those adverse effects? Again, logically, it is very difficult, if it is not impossible, to prove something that do not exist. And we do not find the adverse effect. There are two possibilities. And one is the adverse effect, the significant adverse effect may not truly exist. But on the other hand, it is also possible our current technology is not good enough to detect such an adverse effect. Just like the vapor from amalgam, when I was in dental school, we were taught, quite a few people said that, it would not emit the vapor, but now we can find it. So coming back to the question, if we want to have definitive evidence that that can dispute the adverse effects associated with amalgam, that would be much more difficult to do. We need to probably consider what is the amount of the evidence is adequate to support either way. And I think we need to take that into consideration when we try to answer these questions.
Yes, just Dr. Kurbitz, to add to what you had said, if you take the safe, again, going back to the safe concentrations that have been established by different groups chronically, and then you go and estimate, as our colleagues at FDA have done on page 10, the range of intakes that's associated with amalgams, you find that the value of 5 micrograms per day is at or very close to the amount that you would get from the safe concentration per day. And it therefore follows, if you're going to have some people in excess of that, and 5% of the people apparently are, then you're going to have 5% of the people in excess of the safe concentration, and maybe sensitive individuals would start to exhibit effects. That's consistent with what I believe the Swedish authors are stating, put in a little bit more quantitative way.
And if the 5 microgram daily intake from amalgams is an underestimate, if it's more likely 10,
If it's an underestimate,
then
over.
then the average person may be above the RFC.
Right, and the usual interpretation of exposures above the safe concentration is effects are more likely, they're not certain, but the higher you go, the more certain they become, and the first individuals that would become, that do exhibit effects would obviously be the sensitive individuals by definition.
And let me be clear, I'm not suggesting that the 5 microgram number is wrong or is low. I'm just saying the state of knowledge is one that is characterized more by uncertainty than certainty, as best I can tell. But Dr. Goldman and Dr. Amlar.
However, one thing that I think that is important to note, and that is that we are not looking at the cumulative impacts of the amalgam-related mercury with fish-related mercury and other sources. There's only one paper that attempts to look, that we got, that attempts to look at both exposures to inorganic and methyl mercury to see if those effects are additive or competitive or synergistic, and it appears to be at least additive, if not more. And that's, another thing that needs to be factored in, which is that people are not starting out with a baseline of 0 mercury. There are other sources of mercury.
I just want to come back to Dr. Hughes. Would you just comment on your readout of the direct adverse effects that you mentioned from the literature? I presume that we're talking about the 2 randomized clinical trial. Am I correct?
Primarily, yes.
The conclusions are, and I'm reading what I see, none of the parameters evaluated reached statistical significance. So if we look at randomized clinical trials, we have to have statistical significance. And in the absence of statistical significance, I'm still wondering, unless I read you incorrectly.
I think the point to make is, if you look at the primary endpoint of the US study, for example, it's looking at an IQ score. And they powered the study to look for a 3-point difference and judged that to be clinically significant. So this is a 3-point difference on average between the two, the amalgam arm and the composite arm. And so they didn't find that difference. There was no statistically significant difference. Having shown that there's no significant difference, within the paper there's also a confidence interval for the difference between the two arms. Now that confidence interval, one interpretation of it is that it gives you a range of true differences between the two arms which are compatible with the data that's been obtained. And that confidence interval, I don't have the exact numbers in front of me, but the bounds of the interval are less than plus or minus 3, if I recall rightly. So in other words, the true difference is reasonably likely to be smaller than the difference which they considered clinically significant when they designed the study. So on that basis, you might argue that it provides direct evidence that the adverse effect with respect to that particular neuropsychological outcome is likely to be small, at least over the short term, and not clinically significant.
But that would be, at best, with the confidence interval, as you mentioned, of 3, potential correlation and not direct evidence.
Well, it provides direct evidence that the difference between using amalgam fillings and composite fillings is not producing, or it seems unlikely to be producing, a larger effect on average on neuropsychological outcomes than the 3-point difference that they thought was clinically significant when they designed this study.
And I mean, in fact, if you're looking at the data, some health outcomes are better in children who are randomized to amalgams than and in a way, these randomized studies, come to the nub of the question, which is, it isn't whether you're going to get a restoration or not, it's what the restoration is going to be, amalgam versus something else. Comparing just people with amalgams versus done with no restorations is not as good as the pointedness of this question, at least to my read. And certainly as best as I could read from these, and I understand the difficulty in the external validity or the overgeneralization from a randomized study to other populations, but at least in terms of the health effects, ignoring their urinary excretion of mercury for the time being, there's really no difference between the two. Now, 5 may be too short, maybe.
That's what I was alluding to.
Yeah.
So
That's what I was alluding. And I'm truly trying to find the evidence here.
But let me
wholeheartedly
make sure I'm clear. What we're saying here is there is evidence from these studies that mercury vapor is not causing problems. I mean,
Dr. Goldman.
it like any study has limitations, follow-up, but okay, that's what the studies are saying, and that's the evidence.
Yeah, I think that we have to say that those studies they're well-designed clinical trials. I can't really see much to criticize in terms of the ways that they randomized the subjects, the measures that they used, the neuropsychological measures, the exposure measures that they used, the follow-up. I thought they were done very well, and I think that they were very clear, the authors, about the limits and the fact that, one, there could be effects that are smaller that they simply can't observe because the studies may not be powered to observe smaller effects, and two, that there could be longer-term effects in other dimensions. One area that I am concerned about here, and that these studies did not assess, and that we did not receive anything about, and there's nothing about in the white papers, and that is the area of immune effects, the immunologic effects that have been documented in some of the toxicology literature for mercury were not assessed, and by design were not assessed in these studies because they're newer. And I don't think these studies tell you anything about that. But they did, and I think it's truly marvelous. They did look at cardiovascular effects, which most studies haven't done. And as you know, those were negative, or as you said, some of them even going in the opposite direction. So I think that they do provide some evidence, and I think they're certainly very reassuring, and that this committee ought to be able to be clear that if you have a child that's not performing well in terms of IQ, that although there is some chance that there are subpopulations that are more impacted, there's no way that we can say that, but that generally we wouldn't expect to see an effect on IQ from children having these feelings. I think that's a very important thing to be able to say in terms of reassuring families, and I think those studies do show that, even though they can't prove that there isn't some small subset of children, that aren't more impacted.
Dr. Hughes and then Dr. O'Brien.
I think the other major caveat with these studies is the amount of mercury exposure, at least if you look at the urine concentrations, the difference between the two arms may be relatively small. So looking at the US study, the mean concentration at 5 years after baseline was 0.9 in the composite group. 0.9 in the amalgam group and 0.6 in the composite group. So it's a relatively small difference in terms of exposure. And obviously, if you have no difference in exposure and you think it's the mercury causing the difference in the primary outcome, or it's the mercury that would cause any difference, then no exposure would mean no difference. So the difference in exposure is relatively small.
Do you think the N number, was not enough to provide sufficient power to the study, and a larger study would allow to detect minimal effect, if any? Because we're talking about here an effect size, am I correct? And apparently the effect size is minimal to be picked up by the approaches that we have. So my question is, would a larger randomized clinical trial pick up minimal differences?
I think, I work with a lot of pediatric clinical trials, not in the dental setting, but a 3-point difference in mean IQ score is a relatively small difference. These studies were well powered to detect the sort of difference they were interested in. So I would consider, at least for the primary endpoint, that these studies were well powered.
And the primary endpoint being the IQ. And within the IQ, it's reassuring that amalgam, am I getting this clear? That amalgam does not affect the IQ?
Certainly, it doesn't appear to affect it substantially at the mercury exposures observed in this study and over the duration of this study.
I mean, I think, Dr. O'Brien, I'm sorry.
Very reassured by the studies that are in the study, especially the recent one, Journal of American Medical Association. But I think we're missing another point. In other words, dental amalgam seems to be safe when used from all of these studies. However, there's a wider risk in the real world, and that is that mercury is ubiquitous in the environment. Recent reports that I have heard that we are the Saudi Arabia of coal, and that especially in Wyoming, the increase in coal is going to be much higher to make up for the lack of petroleum. So that there is an inherent risk in amalgam that other gold alloys don't have, for example. They have a gold amalgam, a gold alloy, for example, or a composite material. You don't have to have the risk of a perfect storm of some individual lives in a house where there's a broken mercury thermometer and then eats fish 3 times a day. There's no risk involved with these other restorative materials that you have potential in an amalgam because it's cumulative. So that the studies are reassuring, there's nothing wrong with the amalgam procedures as given, but in the total environment, in the system that we live in, it has an inherent risk that needs to be recognized. And in addition to dentists telling their patients who receive a new amalgam, don't bite on hard food, they might also advise them, don't eat fish for a week.
I think it's a good point. I mean, I think that several speakers have alluded to, excuse me, that aside from amalgam, which does appear to be the or one of the 2 major sources of mercury, there are other sources of mercury in the environment and in the food chain which add to the total risk. And that needs to be in that context. Dr. Diamond, then Dr. Olson,
Yes,
then Dr. Sacco.
I'd like to respond to Dr. Amara's concerns. My old statistician professor had, told me that human, and pretty much it's widely accepted that human beings have an incredibly variable, response to any kind of stimulus or drug or any kind of treatment effect. So in a controlled clinical trial, if you're trying to focus on one particular outcome, you have to eliminate as much of the variability as possible. So the concerns, like, for example, in the American study, they excluded any physician-diagnosed psychological, behavioral, neurological, immunosuppressive, or renal disease as a confounder. So you try to create as homogeneous a population as possible to permit a valid comparison of the 2 treatment groups to address issues of finding any kind of safety concerns. Those are generally, as we know, even from many drug approval processes where a lot of studies are run with very large patient populations, a lot of things you don't see until a product is released on the market and it's exposed to, when you have a much broader exposure in the population. So you may not, so to pick up a safety blip, even a blip on the radar screen, you might need, tens of thousands of patients to be exposed before you might see it. And you might not get this in a well-controlled trial.
Dr. Olson.
Yeah. Going along with some of the discussion about other sources, I was struck when I first read both the Bellinger study and the Durand study that in the Bellinger study, the mercury from the composite group indicated that more than half the mercury in the urine is from a source other than dental amalgam. And similarly, in the Deveron study, it was 2/3 were from other than a dental amalgam that didn't have any. So I thought this was extremely interesting data that talks about using the urine level with the creatinine that we've talked about already, that if you think about that, you could, and being conservative, you could say, okay, well then at least half of that doesn't come from dental amalgam. And it comes from, obviously, elsewhere in the environment. So, as I said, that struck me as being important, considering about the toxicity of the amalgam.
Dr. Sacco?
I wanted to go back a little bit to this idea of the randomized trials, and I guess weigh in again a little bit more heavily in terms of the weight of the evidence. I think Larry mentioned and others mentioned that randomized trials, we grade these as level A. There are 2 of them, so we have concordance between 2 different randomized trials, albeit given the statistical considerations that Dr. O'Brien has mentioned, they're there, but these are still important findings, and I think the only thing I'd add is that we focused on the primary outcome, but there are secondary outcomes that also did not show any differences, nor any differences in multiple adverse health conditions reported during the 5-year follow-up that were even more frequent, including things like allergy and skin disorders. So I weigh these trials, at least when I look at the data, as the heaviest, most direct evidence that we have that don't show that much of an adverse health experience.
I think the New Zealand Defence Force data is also, I mean, it's 20,000 people. I think it's a large accumulation of people with exposure that's also relevant, not of the same quality of evidence in terms of inferential reasoning, but still a large and important accumulation of information. Same for the ranch hands and for Factor Litvak. I keep wanting to reverse the name. Other comments?
Yeah. Not to argue with not to discuss the epidemiology studies from this, but going back, and I keep hopping back to it, again, is the earlier studies by Fowle that were used to set the reference concentrations. And Michael, you went through this, so please correct me if I'm wrong, but as I see it, the average exposure level in those workers where there was small but observable effects was about 25 micrograms per liter of urinary mercury, and given how much of that's where that comes from, we don't know. I know, but and then in the general population with amalgams, exposures average can average up to 3 or 4 micrograms per liter based upon the number of amalgams, and can go up to 15 or 16 micrograms per liter of urinary mercury in some individuals. So that's the high range. I don't know what percent of that population would have that high level, but if it's a total U.S. population, that can get probably a goodly number. So the argument would be that you're looking at a difference between 26 micrograms per liter in a worker population versus potentially 17 micrograms per liter in the U.S. population on the high range, which might be a significant numbers. How much of that is contributed by amalgams, we don't know, but some of it is. And we're not that far away. I mean, we're not far away from levels that seem to have potentially an adverse effect.
Yeah, and although I go through the numbers a little bit differently, I would agree that what we appear to have is exposures to the general population with amalgams that are at or very close to the safe concentration. So the Falwell study was 25 micrograms per meter cubed of air, and the way EPA and others took that information is they adjusted it for continuous exposure,
right,
which was 24/7, 24 hours a day, 7 days a week, because the workers didn't get exposed to that. Then they took that reduced level in air and they divided it by uncertainty factor because the study was not perfect. We haven't found one yet that was. And so you've got a 30-fold uncertainty factor net. And the three different federal agencies, with the Dutch being the third federal agency, all kind of characterize that these uncertainty factors differently, but they all come up with the same endpoint. And that safe concentration that's good, safe 24/7, is in the range of where people seem to be exposed from amalgams right now, on average, or I think it wasn't on average, there's 95% or lower are at that
No,
level.
the average would be around 3, but there is a group, but the range goes up to 17.
Right, and then the question then becomes is how do you track those urinary concentration or levels back to, what is due to vapor itself, which is a question. And then
Right.
when you've got that determination, what level is that consistent with in air? And once you have that determination, you compare it to the safe concentration, you say you have a problem or you don't. And that's the basic concept, right?
I think, if we were talking about an intervention that might encompass 10,000 or 100,000 people, we would not be having the discussion we're having, because we're talking about the very tails of distributions. But we're talking about an intervention that has hundreds of millions of people, and the tails constitute maybe tens of thousands of people. Is that fair?
If I may.
I think there's, so many problems. I mean, one is these numbers, when you dig into these numbers, for example, the occupational numbers, the urinary numbers, well, I'm not sure that those numbers really are representative of what the exposures were in those work environments looking at those studies, because the studies were done at a certain point in time, and probably many years earlier, many of those workers had higher exposure levels that were not measured. You see, so just because, as I said before, just because it's an occupational study and it's a higher level, it doesn't mean that the data are done accurately. And the effects could be from higher levels earlier in those studies, but we don't have any way of knowing that, looking at those. So it's hard to do kind of what is the MOE between those people and people today, because those people weren't maybe measured, at times when they were more highly exposed.
MOE?
And margin of exposure. So, and then the other thing that we see sometimes, despite use of uncertainty factors like 30, is this an uncertainty factor? Well, we use uncertainty factors because we're uncertain. And one of the things we're usually the most uncertain of is uncertainty, or as I think Yogi Berra said something about, the only thing I'm sure about are the things I know that I don't know, or something like that. But one thing where we've been very far off on uncertainty factors in the past, and why I keep going back to this fetal exposure thing, is with the gap in where we observe effects in the fetus and where we observe effects in adults. And those levels have sometimes been much farther apart than 30. Sometimes, hundreds or even 1,000-fold difference between a level that causes an adverse effect during exposure to the fetus and a level that causes an adverse effect to an adult. And that is, so in my opinion, you see that 30-fold factor does not take that into account at all. And I'm not sure there is a way to take that into account. I think you need to directly observe what's going on, and that the studies that are available really don't do that.
Just thinking of question part sub C and D, getting to that. I mean, indirect evidence. I think there's no direct evidence of impaired fetal outcome or gestational outcome in amalgam exposed people versus not, although there's a lot of indirect evidence from animal data and just reasoning about mercury's ability to interfere with the developmental process. But just sort of the difference between direct evidence. There is some direct evidence in Swedish workers exposed to mercury, but included a number of professions, including leather workers and other things associated with small for gestational age, but I don't think there's any direct amalgam. Dr. Goldman, then Dr. Fleming, thanks for being here.
Yeah, I mean, I think we can look at it more carefully, but I actually think that there are some birth outcomes have been examined in humans, not with studies that are as good as the studies as high quality as the studies that have been done that we've discussed earlier about the actual effects directly to people with fillings. But there have been some birth outcome studies, there have been some reproductive studies that do provide some evidence, but there have not been studies to look at that specific issue of developmental neurotoxicity, kind of like the Bellinger study, but the design instead would be the mothers, whether the mothers had mercury fillings or other kinds of fillings, and then but doing the same kinds of assessments, the neuropsychological tests. There are no studies like that at all.
Neuropsychological test of the subsequent delivered children.
So the children
But-
and following them through
Yep.
grade school and so forth, as has been done, for methyl mercury and lead and some others.
Thank you, Dr. Fleming. Sorry for...
Briefly, I just wanted to introduce another confounding factor to this whole business of exposure. One of the things that we have to consider is the juxtaposition of other metals next to amalgam or over amalgam, which would increase the release rates dramatically. So if you have a pregnant woman who has a gold crown or perhaps a nickel crown or amalgams adjacent or underneath, you're going to have a much higher level of exposure potentially than you would in, say, a child in the amalgam trial who may just have only a few amalgams. So it is a confounding factor in our understanding of what the daily dosage would be. It can be much higher in some individuals, very small in others, and variable in the same individual from day to day, hour to hour, meal to meal. So that's another confounding factor in risk assessment.
Well, we're about to take a break, which we will break shortly. For a short period of time when we break. But I just want to sort of summarize. We've talked both about direct and indirect evidence, the paucity of direct evidence showing any adverse health effect of amalgams, the lack of information, the uncertainty about the actual exposure from amalgams, both in the acute and to a certain extent the chronic setting, how to best measure body burden, and that there's apparently a great deal of variability among individuals in the exposure they experience from amalgam use. Trying to think of what else we said we didn't know much about.
That last point that was made, we heard a lot about that kind of thing in the cases that we heard about over the last couple of days, the testimony that we heard. And if anybody on the panel has factual information that can contribute on that, is there really something that can go on with juxtaposition of these metals and so forth? I don't understand that, so.
And a particular concern about the possibility that the ratios between what is relevant for an adult occupational exposure to what might be potentially phytotoxic, we don't have a good handle on what that ratio might be. Dr. O'Brien?
It's well established that if two metals are in contact in the mouth with the saliva as an electrolyte, the electrolytic cell will be set up. And it's not, this is a common occurrence. In fact, you get, dentists will commonly get calls over the weekend in the course of the year. And in the case of the amalgam versus the gold, for example, the amalgam will be the anode and will dissolve electrolytically rather than just by solubility. So, but that is all dental schools, we warn that. We warn the students about that quite a bit. But I doubt if any of these, what I call it, uninformed dentists would end up in one of the studies that you find published in a journal, so that when we look at these published studies, they're done under the best conditions.
These cases that we heard about, that could be a possible thing going on with some of these,
Yes, it can be the effect that it's been reported in the news and actually verified that the electrical currents produced can produce radio signals, and the patients can hear radio stations and they get a buzz. But the common thing is when an amalgam is put in, for all patients, if they happen to touch the amalgam with a fork, this is universal. They get a shock, or aluminum foil that might be in some of the food that they're eating. So that is another hazard, but really is not, wouldn't be a concern for the use of amalgam, but rather the correct use of it.
Very briefly?
Very briefly.
Okay. Indirect evidence that we've, I think, all talked about, I just kind of clarify in my mind, was the testimonies from the public, some of which would probably be characterized as indirect evidence, and also the Falwell studies, which were mercury vapor studies, but not amalgams, and then taking that information and sifting it down into the estimation of a safe concentration would be obviously indirect, since it's not an amalgam study itself.
Right, and that in addition to the other animal work we referred to for. Okay, 10 minutes. That means 10 minutes from right now. Thanks.